Support for To The Point comes from Bausch & Lomb.
Beautiful and healthy looking eyes? It shouldn't be a compromise. Lumify Eye Illuminations, developed by the experts at Bausch & Lomb exclusively for the sensitive eye area. To cleanse, nourish, and brighten. Lumify Eye Illuminations, only in the eye care aisle.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my lovely co-host, Jessilin Quint. Hi, Jessilin. Hello. Good evening.
Hello, Jackie, and hello to all of our listeners, and hello to our guest.
Okay, we are so excited to be talking tonight about dry eye and our surgical patients and how we can prep our surgical patients to have great surgical outcomes and really deal with our ocular surface before we send them for surgery. And so for this podcast, we brought in the big guns for this. Please welcome Dr. Nandini Venkateswaran. So let me tell you a little bit about Nandini. Nandini did her residency training at Bascom. She did her fellowship at Duke. She's incredible on the podium. If you have never heard her lecture, please Google her and listen to any of her videos or webinars that she's done. She is one of those lecturers where you really just feel like you really understand the material a lot better, and she presents it so lovely, and she's a joy to listen to. So please Google her for that reason. And as a little fun fact about Nandini, she loves to golf, and she likes, like me, loves an espresso martini and a margarita. Nandini, yes, girl.
Welcome.
Thank you so much for having me. It's the best introduction I've ever received. You guys make me blush.
We should have recorded this from the golf course with espresso martinis in hand.
That would have been the ultimate win. All three of us, just on the course, chatting about dry eye, because we all know being in the outdoors exacerbates dry eye.
Exactly right. It's exactly
no more
right.
Golf, no more golf.
You are, a surgical just guru and a total rock star. How did dry eye come about with a lot of your surgical patients? Like how did this roll out? How's it changed over the last couple of years for you?
Yeah, what's shocking to me is, and I think all the listeners here know this, how prevalent dry eye is. And I think we've had a few studies in the literature that have shown that upwards of 60 to 80% of patients who come in for cataract surgery evaluations actually have dry eye. And probably over half of them don't know that they have dry eye. So really the reality is that probably every other patient I see has dry eye. And so for me, the ocular surface examination is mandatory for any of my surgical evaluations. So I think having a really streamlined approach to looking at the lids and lashes and the surface takes me about 30 seconds. And that part, I put in the back of my head, and then I proceed with the rest of the cataract surgery evaluation. And I've just realized that I have to have this conversation more often than not with patients. And I think the biggest teaching point to my patients is, garbage in is garbage out. If I don't have good data for you to help me understand your optical system and understand what technologies I can offer you, then I'm not doing you justice in terms of giving you the best possible surgical outcome. So that's why I think, many of us have started to really emphasize the importance of dry eye disease diagnosis and management in a surgical practice.
I think we've all seen these cases where our cataract surgery patients have come back and they're unhappy and feeling like their dryness that they now experience post cataract surgery is a result of the cataract surgery, when in fact they had dry eye before they had cataract surgery that just wasn't properly addressed. So, when I send you patients, or when anyone is sending a patient to a cataract surgeon, What are your tips? I mean, we know we have to optimize that surface so that we get better results for your biometry and all of the measurements that you're taking pre-surgical. What are some of your tips on how to best do that? I mean, sometimes we'll run into cases where someone's really antsy to have cataract surgery and we want to do it in the quickest way possible. Can you tell me like what steps you do if you need to prime this surface before surgery in what your sort of algorithm is for that?
Yeah, that's a great point. And I think as I've been in practice a little bit longer, kind of I've kind of addressed the antsiness and been like, that's okay. I think we really need to take the time to prioritize this. And that was hard for me to say in the beginning because I too was anxious. I'm like, I want to do this patient surgery. This patient's in my chair. I want to get them in and out. And that's the goal. But then as you start to see unhappy patients, you begin to realize, second referrals, et cetera, that you're like, I'm seeing why addressing this is important. And so I kind of start off by telling the patient this is probably going to be a 4 to 6 week journey before I'm ready to do your cataract surgery. And this includes maybe 1 to 2 more visits with me in order for me to determine, do I have the best measurements? And then what our ultimate plan is for surgery. And then usually for the patient, say I'm meeting them for the first time and I'm seeing that they have maybe some punctate keratopathy, some lid margin disease. I'll usually start a little bit of a topical steroid to kind of calm down the inflammation. And then over the counter therapies, tears, gels at night, some lid margin treatment. And then depending on the severity, I might start, say, an immunomodulator or even a nasal spray. And if I think there's really bad MGD, I'll encourage them to do a thermal pulsation treatment in my office. So I'll stratify based on, how severe I think their infestation of glands are or how bad the keratopathy is. And then I'll say, listen, be as good as you can for about 4 weeks. I want you to come back and then I'm going to repeat your measurements and I'm going to compare and let's see if things change or they're staying the same. And I'll also take a look at the surface of your eye and decide if I think things are improving. I like to get kind of a verbal pact from the patient that now we're starting this journey together. Let's try to find a plan that works before, because then you'll be completely equipped after surgery. So you already know what to do. It's not like we're reinventing the wheel after you've had surgery. And I've really kind of changed my informed consent. I mentioned dry eye for all risks of surgery. Because the reality is, where any ocular surgery I do will induce a degree of dry eye. It will. And so being quite upfront with the patient and transparent about that can be very helpful. Just like, say, I talk about multifocal IOLs, glare and halos are a reality. I'm not trying to hide it from you, but I want you to understand that it's there. But can you be that 95% patient population that'll be okay with it? Think about it for yourself and your personality, and if that's worth it to you. So that's worked in my humble opinion. Like, maybe some patients may seek care elsewhere if they're eager to do surgery sooner, but I have also found that I'm able to convert my patients to premium lens technologies easier because I have good data and I feel confident that they will continue to have a good tear film and good vision after surgery. So that gives me more confidence in making those recommendations.
That's really valuable. I think particularly about this speed and making it very clear up front the length of time this is going to take. I mean, I think we're all kind of like, we want the patients frustrated with their vision. We want the patient to be seeing better. But as you said, garbage in, garbage out. And I think putting that expectation, like this is the road, and we want to make sure that we're getting the best measurements possible before cataract surgery is certainly very helpful. And I really like that you've changed your consents to mention dry eye, being a possibility, or certainly some level of inducing dry eye post surgery. And I kind of relate this to a patient. Like, if we are sitting on a high level of dryness, like we are sitting up here in terms of inflammation, little things will tip you over. I say this about allergies or environment, and surgery can be one of those things as well. So for me, I say I want to bring you down to my lowest level possible, so that even though we're doing a surgery, it's not going to tip you into being very symptomatic from a dry eye perspective.
I love that. I think that's so nice. And when you ask what can referring doctors do, I think have this conversation. You might save that patient that 4 to 6 weeks that they have to maybe work with me if you're able to kind of equip them with the tools. And I think the beauty is that they continue that relationship with you after surgery. So that's super important to me. I'm meeting your patient. Let me do a really great surgery and then let them continue care with you. right? And so they can continue their postoperative care, their dry eye management. But I'm also the partner there that needs to help. Say they develop PCO or there's some refractive error. Like, how can we problem solve through it? And I think patients really appreciate that. I think when I see patients ready to go and they have this regimen, I'm like, kudos to your doctor. That's amazing. Now you're one step closer, and let's jump into it. I have a surgical date in a few weeks. Let's get the ball rolling. And I think that makes for a really positive patient experience.
I think highlighting that 4 to 6 time for referring doctors is really important. Like, it's rare for us to make a referral and then the next day the patient has, like, a cataract consult, right? Like, there's generally a pretty big leadway, which is the perfect time to, get maybe that referral in process, but to use that 1 to 2 months, as you're waiting for that referral to happen, to clean up that ocular surface. Because as a referring OD, while it's, I want the surgeon to do a great job, at the end of the day, I'm with that patient back for like, every year for the next hopefully 10 plus years. And so as a referring doc, like, I want that surgery to go as optimally. I want that patient to have the best experience, to just think that it was the best procedure ever. And so there's a role in that of making sure that that patient is ready to go. I never want to waste my surgeon's time either. Nobody likes their time wasted. So I feel like if for us, for as referring docs, if we're not taking the time to clean up that ocular surface, it's really just it's kind of wasting time, the patient's time, surgeon's time. Like, we can really play a really big role. For patients who maybe are really dry eye, like I've had some dry eye patients where we talk about the risk and how, we really need to kind of clean this up before we get to the point of cataract surgery. And so even for patients that aren't ready, that they know that the surgery is coming down even in a couple years, sometimes my really like super compliant dry eye patients will get nervous about cataract surgery because I think it's going to like tip them over almost and set them back because we've talked about the risks. So have you encountered any patients like that? And for that segment, any tips other than we know that it happens and, we can do some things to kind of mitigate that on the other side of surgery?
Yeah, I think educating them that it's common. I think sometimes people feel that they're on an island and they have this problem and they're the only one who has it. And I'm just like, guys, like 80% of my cataract evals probably have dry eye. So like you're very much in the norm, if anything. And I think, at the end of the day, we're acknowledging it could potentially get worse, but let's make sure you're doing all of this. And the thing is, you're in a time where we have so many therapeutics for dry eye. We're not going to run out of options really quickly. And I think I find myself saying that a lot, especially even with like new dry eye evaluations, because they're like, gosh, like what can I do? Like, I don't think I have any options. And I'm like, I keep changing my list. Like my little handout has to be updated every like 2-3 months because there's a new therapeutic out that I'm starting to utilize and having really positive outcomes. And it's funny right now, it's on my to-do list, but I'm like crossing out certain ones and putting like the new one that I'm using on. But this is a beautiful time to treat dry eye because I have a lot to offer and I also have targeted therapies. So I get to really identify the etiology of your dry eye and then say, listen, we have an FDA approved product for your evaporative dry eye. We have a nasal spray that's going to stimulate endogenous tear production. We have really great immunomodulators. We still have our tried and true punctal plugs and punctal cautery. And I mean, in my cornea practice, I'm using autologous serum a lot. I have a lot of refractory, very severe dry eye ocular surface disease. And so even some of my cataract surgery patients are being optimized with serum and using serum after. So I think giving them the sense of what everyone else out there is going through is very helpful. And even for refractive surgery patients,
Yeah.
because the young population, they come in with, similar degrees of dry eye.
Yeah. I don't have the technology that you have biometry wise when you're prepping someone and taking measurements pre-op. So do you have a suggestion on the best ways to monitor? Like, should I just be repeating a topography every few months to look at that for stability before I'm sending them over to you in terms of, I think maybe the cornea looks better, but this tear film could still be kind of and creating some irregularity on the cornea. Do you have a tip for providers who don't have this kind of technology on how to gauge improvement in their dry eye patient before they refer?
That's a great question. I mean, a lot of it I would say is clinical. I mean,
Yeah.
if you're able to manage patient symptomatology. If they're feeling more like simple things like fluctuating vision, is their vision stabilizing subjectively for them? What does their tear breakup time look like? How is the surface looking? I mean, I'm not even doing that much fancy testing in my office. Like the fluorescein strip is my most powerful tool, and that gives me a wealth of information. But topography speaks volumes. Like the first thing I look at before I walk into a patient's room is their topo, and if the Myers look wonky, I'm like, okay, something must be up. Or if my techs are telling me they put artificial tears 3 times before they could get a scan, then that means they have an unstable tear film. So no one really needs to invest in that as they're referring. But if you have the luxury of having that, use it as an aid, right? If you're having a hard time capturing the image, if the Myers or are irregular, that might be a sign that they're still not stable. And it might also be a point where you're like, hey, let me let the surgeon look too, and decide if it's okay or not, because that threshold also, we utilize multiple imagers. So that helps, all of that imaging together helps us make that decision ultimately. But I think what you are doing simply clinically in the office can be more than enough.
What are some of your pearls in managing your dry eye patients? Give us some of your good take homes for our listeners.
I mean, my biggest take home is I think use a multimodal approach when necessary. I feel like sometimes just using the same thing for every patient doesn't work. And so if that means being creative in terms of which immunomodulator you use, the patient's coming out and has said plugs have fallen out 3 times, maybe consider punctal cautery. Or if you have a patient that's failed so many therapies, think about autologous serum. I've even used Procera or amniotic membrane in some severe cases where there's so much keratopathy and discomfort. So I think having multiple treatments up your sleeve have been the biggest asset for me. And I think patients are really grateful when they're like, okay, cool, I still have options out there that I didn't think I had before. And I think now with treatments for Demodex blepharitis and all of our lid margin treatments, we've really also addressed MGD. And I think a lot of us know evaporative dry eye is probably the most common type of dry eye. So having really good, strong therapies for that makes your tear film look really good.
I love that clinical pearl. I think sometimes too, because we want everybody, like all docs, right, to really bring ocular surface to every patient if they have it. But sometimes the message then is like we oversimplify because we just want more people on board. And so then we kind of just get stuck in these habits. But just like any healthcare, any plan, it's really an individualized approach. It's a curated plan. And so I like that reminder, like step outside the box, especially if something's not working, and try something else.
Yeah, I think that a lot of dry eye patients sometimes get to this point where they feel like they've tried so many things when in reality there's so many other things that they can try. And so for me, I'm always like, just so you know, this is not the end of the road. We have a lot of other treatment options for you if we are not getting the success we want. So I think a lot of treating a dry eye patient is encouraging, right? Like you're just offering encouragement. You're doing great. I get that this is a burden of treatment. How can we make this simpler? What other therapies should we be exploring if this isn't working? So I think a lot of it is just like, coaching and like being encouraging, like you're doing great with these therapies, and also not letting people lose hope that there's nothing else that they can do for their dry eye issues. So
Absolutely. And I think another thing is sometimes if what you're doing isn't working, think outside the box. I think there are several dry eye masqueraders that we sometimes overlook because, again, we're thinking dry eye, but I can't tell you how many tearing patients I have that I refer to my oculoplastics colleagues that have a degree of NLDO or nasolacrimal duct obstruction that need treatment. Even conjunctivalis, I think, is underrated. That irregular conj inferiorly can lead to a lot of instability in the tear film and tearing. So there's just some other, pathologies you should think of, and other lumps and bumps on the cornea. Do they have anterior basement membrane dystrophy? Do they have some hidden Salzmann's nodules? Lift that eyelid and take a look at the superior cornea. So I always remind myself, if it's not working, 1 or 2 times, am I missing something? And I think it's an important reminder for all of us that, again, different scenarios can be, unique.
That's so true. I think one time I started making a list of all the masqueraders, and there was like 18 or like 22 different. It's not just like five, but like when you really start to look at it, and I was like, yeah, can't forget about those. They're sneaky.
Yeah,
Dry eye in
absolutely.
disguise.
Totally, totally. And then your patient's like, wow, no one's told me that before. And then you're like, yeah, let's go treat it.
Absolutely.
That's kind of
Well,
fun.
this wouldn't be a to the point, episode if we didn't also hear about your life lens. So, what is something that you can't live without or has been a game changer that's added value to your life? This is my favorite part sometimes I feel like of our segments because I always get new tips or products to try.
You know what's, I don't know if it's a life lens, but it's been a habit that I've really tried to incorporate probably over the last 3 to 4 months, and that's having movement every day. And I think that's actually really hard to do in New England where the weather is terrible. But I actually do some of my best thinking when I go on outdoor walks. And I love them. Like I go on a walk, whether it's a phone call with a friend or I'm listening to a podcast or I'm just like in silence in nature, I actually can kind of process things, or like if I'm trying to solve a problem or if I'm, ideas pop into my head, and it's underrated. It's like so simple, but it has kind of changed my mental health and my mindset in a really huge positive way. So I'm brainstorming how I can continue to do this in the winter, but it has really also made me like love working out more. I'm so much more active than I was. And I don't know. I just think being outside and getting sunshine is so important and helps you a lot. It's my life lens. It's a simple one, but
No, but that's really perfect. I feel the same. I discovered walking. I was always feeling like, oh gosh, I'm going to work out. I got to be like sweating like crazy and running hard. And then I realized I don't have to do that. I could just take a walk. And that is very like, it is good for your mental health and good thinking time. So I love that one. That's a good one. I totally thought you were going to say golf.
well,
That's
golf too.
That's
Golf is
movement.
meditative too, right? Because I'm walking outside. Like I don't look at my phone. It's amazing how you can be so disconnected from the frenzy around you. And I'm just like, you have to kind of think about the ball or think about what you're doing. But yeah, I think it's nice. It's nice to just almost be in silence sometimes with nature. It's
totally.
Yeah.
That's
That's really
great.
good. That's very
Nandi,
good.
thank you so much for coming on this podcast. We have loved talking to you. You're the best. You are the literal best. I text you all the time about patient cases. So you are amazing. I love you.
You guys are amazing. Your podcast is amazing. I was just telling you before, number one fan, been listening to like so many of the episodes, and congrats
Woohoo!
on a really, really nice, nice production.
Thank you.
Thank you. Thank you so much for coming on the podcast. I'll see you soon. Let's have a margarita together soon.
Yes, absolutely.
On the golf course.
Bye.
Bye.